Ladies and gentlemen, I'm very pleased to be here at this very significant meeting. So, straight to disclosures, none of which will affect any of the opinions I have to express. In response to Fiona's challenge, I like food, and enough of it, because without it, my bicycle won't go. So there is a story in there. Let's start off at the Newcastle quayside. This is Newcastle upon Tyne. Here we have the River Tyne and our famous bridges. Oops, let's just go back to that. And the Millennium Bridge, prominent in the foreground, a magnificent structure that you can use to walk or cycle from one shore to the other. So here we are looking at the Tyne and its reflections, really perhaps a good place to reflect on the nature of type 2 diabetes. Because unless we know the nature of the enemy, we don't really know what to do about it. Now, over a career that I've spent largely doing acute general medicine and diabetes and endocrinology, and increasingly pure diabetes, there's been a driving question of what causes type 2 diabetes. And in the late 1990s to the early 2000s, we were looking at liver insulin sensitivity and the role of liver fat. And then quite suddenly in 2006, everything dropped into place. And it was possible to write down on a sheet of paper what possibly was causing it. Not a mysterious disease that was complex and had different causes affecting the beta cell, amyloid, beta cell death, apoptosis, oxidative stress, but a single cause. And it went like this. People only develop type 2 diabetes if they've been in positive calorie balance for some substantial years. And that will have the major effect of driving the accumulation of liver fat. Now, our work and that of many groups worldwide has shown the higher the liver fat, the more insulin resistant was the liver, purely the liver. So that will have the consequence of driving liver insulin resistance, and the liver insulin resistance will inevitably lead to basal insulin secretion creeping up because of homeostasis. The body wants to keep down the big function of the liver, which is producing glucose. Hepatic glucose production goes on all the time, just kept under control by insulin. If it's creeping up because of insulin resistance, then that will increase. But here's a funny thing, insulin itself stimulates the process whereby glucose is turned into fat. So if there is insulin resistance, high insulin, that will tend to stimulate the liver fat, and this vicious cycle will begin to run, so that there'll be a tendency, and indeed a real small increase in plasma glucose, which will increase the insulin production, increase the liver fat, and this will spin on until such a time as we get to a point where the liver fat starts spilling over. Now, not only is the main job of the liver to supply the glucose that the brain requires, as mentioned earlier, but also it supplies fat to the rest of the body in the form of very low density lipoprotein triglyceride, quite a mouthful, but VLDL triglyceride. If there's too much of that, it silts up in your coronary arteries and elsewhere. But we know there's one tissue that takes it up quite avidly because of in vitro studies, and also because of the in vitro studies, it was possible to say that decreases the beta cell ability to respond to a meal or an increase in glucose. But in that case, it will cause plasma glucose to stay up for much longer. There'll be insulin around for hours. That is going to drive on your de novo lipogenesis, maximize whatever conversion of sugar to fat is going on. And we have a vicious cycle which will miserably grind on over the years until a point when the system breaks down suddenly and type 2 diabetes appears. Now, some years after that hypothesis, published in 2008, the Whitehall 2 data showed exactly this, 0.6 millimole per litre rise in plasma glucose over a decade followed by a rapid rise over about 18 months. But this is a hypothesis, if you like, a fairy story, built up of observations. And the only point for a scientist to produce a hypothesis is to try and destroy it. So that's what we have to set about. How should we best destroy this? How about cutting off its head? If we remove the positive calorie balance and make it negative, if we're right, these cycles should go into reverse, and we should be able to normalize plasma glucose. Does that happen? Well, we can test it. But how are we going to understand the mechanisms? Well, in order to understand the mechanisms, we need to measure 4 main parameters: the liver fat and the pancreas fat. And we did this using magnetic resonance methodology, developing the necessary methodology. We need to measure this, which is quite easy, and also measuring directly the acute insulin response. So this was a counterpoint study, and we calculated how many people with type 2 diabetes we needed to study to cause this hypothesis to be destructed, and we utterly failed to destroy the hypothesis. We can see that taking this group of people with type 2 diabetes, all agents were stopped after the baseline studies. Plasma glucose normalized within 7 days, and it remained normal thereafter. And further, we were able to show that that normalization in the first week was due to a rapid fall in liver fat, 30% fall in 7 days. And that completely normalized the hepatic insulin sensitivity. I'd add, muscle insulin sensitivity did not change. It's a different parameter. These two things are often confused. What happened in the pancreas followed an interestingly different time course. There was a gradual fall in pancreas fat and a gradual rise in first phase insulin response. Let me just put some flesh on the bones by perhaps taking the flesh away and looking inside with an MR scan, because here we have an MR scan looking across the abdomen. If we look at the subcutaneous tissue here, every pixel is color-coded for the amount of fat at that tiny point in space. The key is here. So red is 100% fat, but just look at the liver, this big organ here. There's a nasty bluish green, and you can see that indeed it's 36% liver fat. One of the surprises of this study was the extent of liver fat accumulation in people with ordinary type 2 diabetes. The average was about 13%. But what happened after the weight loss? Well, rather shockingly, this happened. It went back 30% in the first week, but by 8 weeks, it was down to 2%. So that's the liver side of the story. In the pancreas, we were seeing a slow, steady fall in pancreas fat and a slow, steady recovery towards normal of first phase insulin response. Now, this is heresy. We've known in diabetes for years that type 2 diabetes is characterized by an absent first phase response, and there's nothing you can do that will bring it back. Well, sulfonylureas will make a small increase. If you change the plasma glucose itself, you get a small increase, but normalization, this has never been seen before. So in putting this set of data forward, you can imagine that I ran into controversy. They weren't arguing about the data, it was conflicting with a belief system. But some real questions were asked, one of which was, but the relationship of the pancreas fat to this change of insulin secretion. Surely these people are just losing weight, and so of course the fat in the pancreas would go down. Well, we thought we'd deal with this by examining people with diabetes and without diabetes, matched for weight, bring about equal weight loss, and compare the fat content in the pancreas to find out whether in fact that was true. Here we see the data before weight loss in the red, type 2 diabetes, significantly higher than those people with normal glucose tolerance. And after weight loss, about 13% weight loss, the diabetes people significantly decreased their pancreas fat to a normal sort of level. Normals did not change. there is a small pool of fat in the pancreas, which is specific to diabetes. Two other questions were asked. Hang on, you've only done these studies in people with short duration type 2 diabetes, up to 4 years in the first study. How about longer duration? What happens? And also, come on, this first phase insulin secretion is going to disappear as soon as you go back to eating normal foods. Because don't forget, we devised the very low-calorie diet we used in the first study as a tool to test the hypothesis. It wasn't meant to be a therapeutic effort. It wasn't testing diets for an effect. It was a metabolic tool to perturb the system and find out how wrong we were. So, does this first phase remain long-term? Well, dealing with the first question, these are the results of the second major study that we carried out, the counterbalance study. And you can see that with increasing duration of diabetes, there was less and less likelihood of achieving a non-diabetic plasma glucose level. Indeed, some people with short duration diabetes might not even return to normal. So we're clearly dealing with a range of responses, but affected potently by duration of diabetes. What about the long term? Well, in the same follow-up study, we looked at the effect of 6 months of normal eating. The types of foods were not specified. It was asked that people remain the same weight, and indeed they did. So having achieved the 15 kilogram weight loss, they kept it off over 6 months of normal eating. The liver fat remained at that normal level of around 2.5%. Interestingly, on this slide, here we have the, in general, longer duration people, and you can see that they too normalized their liver fat content and kept it down, but just look at the baseline. Fasting insulin had already fallen significantly in this group as the years go by and the beta cell is really bowing out. Because of that removal of de novo lipogenesis stimulation, perhaps, we were seeing a fall in the level of liver fat. So trying to get rid of the liver fat at that stage was bolting the stable door after the horse has gone. Back to Newcastle. Here we've got Newcastle. It's always nice to have a break from the data slides, and this is our new castle. It was built in 1086, but people don't change their habits of calling certain things very easily. What can we say more generally? Well, what we can say is what was in the paper that Nita brilliantly put together from the list of co-authors there on nutritional approaches for the prevention and the management of type 2 diabetes. What can we say about this? Well, in the first page, there's just one little sentence that might be overlooked, and that is the idea of being on a diet for life is enough to put many people off. So we need to actually see the human side of this, that the relationship between humans and food is not quite what is talked about in nutritional meetings. Food is something that happens in a social setting. And if we overlook that social environment, then we'll rather miss the point of effectiveness in what we're doing. There are two other basic points on that first page. And the first is doctors are highly trained in using drugs and hardly at all with nutrition. And secondly, eating patterns vary in different populations. There's no one size that fits all, and we really do need to grasp that. There's a tendency for us to talk about nutrition as though it was something that only related to people living in westernized countries, whereas, of course, the truth is otherwise. Specifically, we were asked to deal with areas of consensus and areas of controversy. The consensus, weight management, was mentioned in all the guidelines. There's no doubt about that, although the extent of it wasn't much emphasized, and the fact of it wasn't much emphasized. You just do it. Now, in practice, it's often skipped, but the consensus is there. Patterns of food intake? Well, most of the guidelines, all of the guidelines in fact, reflected the need for higher vegetable intake, all the usual things, fruit, legumes, reduced saturated fat, consensus. Foods to avoid, again, consensus, calorie-dense foods. But how about the areas of controversy? So, as we've already heard at this meeting, the optimal macronutrient composition is an area of controversy. But what's going on here? Well, I just point out that the guidelines vary between the European and Canadian guidelines, saying 45 to 65% carbohydrate, India 50 to 60% carbohydrate and less than 30% as fat. The ADA recently has said there is no ideal mix. It's an individual thing. How about defining a low carbohydrate diet? The phrase is often bandied around, but when we look hard, some authorities are saying that it's less than 4%, others are saying less than 40%. Clearly, we've got a problem with words here, and we need to be quite precise about what we're talking about. Dairy products, really the confusion here is over type and how much, always struggling with this existential angst about fats, and especially saturated fats, very reasonably. Oils, now the hydrogenated oils are recognised as being bad if they're mentioned in guidelines, but there is still variation between the guidelines and lack of consensus. Trying to pull things together, how about this prevention business compared with the management of type 2 diabetes? The two are often seen as being different with regard to dietary advice, but we'd like to emphasise that in fact we're talking about the same kind of approach to eating food in those social groups. So we have to see our individuals managing type 2 diabetes as having come from this population, but living within the general population. So in all populations, we would want to manage weight. That really is essential. And the quantity of food clearly matters. As Mike defined obesity with having accumulated more fat than was healthy, that carbon's got to come from somewhere, and it can only come from food. The quality is highly relevant, as Darius elegantly pointed out. Focus has to be on food, not isolated nutrients. And overall patterns of eating are what happens in society. But turning to type 2 diabetes, we now have reversal of the processes underlying type 2 diabetes. How about going for a remission? Or do you not want to do that? Well, we can manage that. We've got very good guidelines. Low carbohydrate, low calorie. Well, any sudden change like that for a person with diabetes requires monitoring and careful observation, especially in view of change required in medications. And we shouldn't miss out the non-dietary factors. Physical activity clearly is important, especially in keeping weight steady after having achieved the step change of weight loss needed to reverse type 2 diabetes. But how about these populations? They differ. India, in the last few decades, sharp increase in fat intake on a background of high carbohydrate intake. How about China? Well, an increase in animal protein and fat with decrease in cereal consumption. South Asia, shift to refined carbohydrate and increase in sugar-sweetened beverage. The increase in our lifetime is staggering. We just take these data from China. So, I think we can put all those factors together, coming back to the Newcastle quayside and reflecting on this whole business. And as you stay with me into the inky waters of the Tyne, hopefully you see something similar to me in the conclusions we might draw. Here we have a potentially reversible state of excess fat within liver and pancreas. Population and individual factors are critical in moving from where we are to where we want to go. And The move to consensus is going to really require some further, very robust studies. Thank you.